Welcome to liver function. The liver is the largest internal organ and is very functionally complex. It plays a critical role in the metabolism, digestion, detoxification, and elimination of substances from your body. It is very unique in its resilience, its ability to regenerate cells, and to repair itself from injury and disease. Some of the other functions include storing amino acids, conjugating bilirubin, and regulating hormones. It is quite large. It weighs 1.2 to 1.5 kilograms in a healthy adult. It is located beneath and attached to the diaphragm, protected by the rib cage, held in place by ligamentous attachments. There's actually two lobes which are connected by the falciform ligament. Very vascular, it receives blood from the hepatic artery and the portal vein. Back when I worked in the hospital, we would have patients that would come in, especially a couple stand out in my mind where they were stabbed and or shot in the liver. It was a very bloody night in the blood bank department trying to cross-match those blood units of blood in a timely fashion for those patients. We also have the bile caniculi. Those are small spaces between hepatocytes that form intrahepatic ducts where all the excretory products of the cells can drain into. Here's kind of a diagram of where your liver is located within your body. It is tucked up high on the right side. When we look at the microscopic anatomy of the liver, we see in the lobules that there are different divisions. They're all responsible for metabolic and excretory functions. There are six-sided structures with centrally located vein and portal triads. And the portal triad actually contains the hepatic artery, the portal vein, and the bile duct. It is important to make note of the two major cell types that we find in the liver. Hepatocytes, which are general liver cells, are large cells radiating outward from the central vein. And then we have the Kupffer cells. Those are the macrophages that line the sinusoids and act as phagocytes, engulfing bacteria, debris, and toxins. They are essentially the garbage trucks of the liver. Here's an example of what those might look like. We have the hepatic cells here within the liver, but then in these sinusoids here where things drain into the blood, you see these Kupffer cells, which help clean up any undesirable items that may be there. Some of the biochemical functions of the liver include the excretory and secretory functions. The liver is the only organ with the capacity to get rid of heme waste. We know a red cell only lives about 120 days. After that, it becomes sequestered in the spleen, and we will have heme waste left over. He is the guy who can take care of all of this. From there, we end up with bile as an excretory product. It is made up of bile acids or salts, bile pigments, and extra cholesterol. The body actually produces about 3 liters of bile per day and excretes 1 liter of it. Then we have bilirubin. This is the principal pigment in bile. It is derived from the breakdown of red blood cells. We have about 200 to 300 milligrams of this produced per day. Most of it is eliminated in your feces and some of it is eliminated in your urine. Here's an example of what happens to a red cell during its lifespan. First of all, the red cell floating in the bloodstream, which may become kind of old and not very healthy, he gets sequestered by the reticuloendothelial system in the spleen. From there, the hemoglobin from the RBCs are broken down into unconjugated or indirect bilirubin. The normal range for that is about 0 to 0.2 to 0.8 milligrams per deciliter. This unconjugated bilirubin floating in the bloodstream then makes its way to the liver where it becomes conjugated and turns into, or conjugated is also called direct bilirubin. The normal range for that is much lower, 0 to 0.2 milligrams per deciliter. This conjugated bilirubin then makes its way into the intestines through the common bile duct where fecal urobilinogen, it is turned into fecal urobilinogen, which is colorless, which is excreted in the kidneys after it's reabsorbed into the bloodstream, and we will detect that as urine urobilinogen, or it turns into fecal urobilin, which turns brown, which is why feces is actually brown. Some of the other things that the liver is responsible of doing is carbohydrate synthesis. So all of those carbohydrates that you eat, an abundance of them, do become stored as glycogen in the liver, and it will be brought back into glucose as needed. Also, lipid synthesis. The liver breaks down fatty acids to form triglycerides, phospholipids, or cholesterol, and it's also responsible for the synthesis of proteins. Lastly, detoxification and drug metabolism. You need a healthy liver to prevent toxic or harmful substances from reaching systemic circulation. Something you may have heard of before is jaundice. People with liver disease or things like hepatitis, they have a yellow discoloration of the skin, the eyes, and the mucous membranes. We call this icterus. And if we have somebody who has this situation, their blood sample, the serum actually looks icteric, we call it. It's got kind of a yellowish greenish tinge to it. This results from the retention of bilirubin or other substances. This usually becomes visible in somebody's skin when their bilirubin results are greater than 3 milligrams per deciliter. Having this jaundice is the most characteristic clinical manifestation of liver disease. We have a couple different classifications with this. We have prehepatic jaundice, hepatic jaundice, and posthepatic jaundice. It's very important to know the difference between these. Prehepatic jaundice is usually when there's a problem that occurs before the liver, such as excessive cell breakdown. Hepatic means that there's a problem occurring in the liver. For example, hepatitis. The liver is diseased and is not able to conjugate that bilirubin. Posthepatic jaundice occurs after the liver. Think of something like gallstones or some other type of biliary obstruction just after the liver that causes those things to be unable to drain into the intestines. A couple other diseases. Cirrhosis of the liver. You may have heard that Uncle so-and-so has liver cirrhosis because he likes to drink all of his cocktails. Well, this is a condition in which scar tissue replaces healthy liver tissue. This is not reversible. Usually chronic alcoholism and hepatitis C infection can cause this. Once you have scar tissue there, you cannot recover from that. We could also have tumors in the liver. 90 to 95% of hepatic malignancies are metastatic, not from an origin of the liver primarily. So things start other places, some cells break off, and they can kind of take up housing in the liver, and a tumor can begin to grow there. Some things that we can consider to be benign would be a hepatocellular adenoma or a hemangioma, or something malignant would be called a hepatocellular carcinoma, hepatocarcinoma, or a hepatoma. Another issue that sometimes happens when we've got tumors or liver issues is portal hypertension. When we have an obstruction to that portal flow, this leads to bleeding esophageal varices and ascites. Bleeding esophageal varices would be like having varicose veins in your esophagus, so you'd probably be coughing up blood and things. Ascites is excess fluid around your liver. Another disease that I like to put in this area, because it does involve the liver, is Reye syndrome. This is a group of disorders caused by infectious, metabolic, toxic, or drug-induced disease primarily found in children. It's often preceded by a viral syndrome such as varicella, some type of gastroenteritis, or an upper respiratory tract infection such as influenza. It's associated with the ingestion of aspirin during a viral syndrome. If you actually look at a bottle of aspirin, it will give you the warning on Reye syndrome. And this one's really interesting to me because one of my friend's brothers had a friend in school, when he was in grade school, actually die of this. So you want to be very careful on what you give your children when they do have a viral infection with a high fever. Aspirin's probably not the best choice. The acute illness is characterized by a non-inflammatory encephalopathy, so they'd have brain issues, a fatty degeneration of the liver, profuse vomiting, and neurological impairment. They actually become unconscious. When we think of the liver, we always think of, not always, but a lot of the times alcohol-related disorders. Drug-induced liver disease accounts for 1/3 to 1/2 of all cases of acute liver failure in the United States. It's the most common mechanism of injury is the adverse immune response to the drug directed against the liver. And ethanol or alcohol is a very significant cause of hepatic toxicity. There are 3 stages of liver injury due to excessive alcohol consumption. The first one is an alcoholic fatty liver. This is mild, and when you stop drinking, it actually reverses itself. Then we have alcoholic hepatitis. This is where there's a lot of evidence of liver damage. Alcoholic cirrhosis is when you've gone too far. It's the most severe, very poor prognosis. That is that scarring of the liver. With all of these, we'll see an increased gamma-glutamyl transferase, or GGT, because that is an enzyme that is highly affected by this type of situation. So one of the things that these patients will have drawn in for the laboratory is a bilirubin. All commonly used methods for measuring bilirubin stem from a technique described by Malloy and Evelyn in 1937, so this goes way back. And we still use a bilirubin reaction with diazotized sulfonylic acid. There's a couple of fractionations of this. We talked about them before. The conjugated bilirubin, which is also known as direct, the unconjugated bilirubin, which is also known as indirect, and there is a protein-bound delta bilirubin as well that we do not routinely test for. You should know that the direct bilirubin is 0 to 0.3 milligrams per deciliter. The total bilirubin is 0.3 to 1.9 milligrams per deciliter. What we do in the lab is we do in most cases, a total bilirubin and a direct bilirubin. The only way to get the indirect bilirubin is to do the total on the analyzer, do the direct on the analyzer, subtract the direct from the total, and that will give you the indirect bilirubin. We do not routinely measure for an indirect bilirubin. None of the labs I have worked in have done one. I'm not even sure if there's a methodology out there to do it. One of the more common ones, and I know I've had 3 babies and all 3 of them have been slightly jaundice, is physiologic jaundice of the newborn. This is caused by the deficiency of the enzyme glucuronyltransferase. When the baby is in utero, what happens is the mom's blood and liver is able to break down that excess bilirubin for the baby. When the baby's gone and the umbilical cord is separated, there's just the baby has to all of a sudden do this on its own, and it needs to catch up. So during that catch-up period of the first week, it's trying to build up more of that enzyme glucuronyltransferase to break down that excess bilirubin in the skin. And until that happens, the baby starts looking really yellow and almost tan sometimes. So what they tell them to do is to put the babies they told me to put my babies next to the window to get some light, or they can put them underneath these Billy lights. They now are sending babies home with Billy blankets, and they're all covered in lights, and they look like little glowworms. But if we were to not treat the situation at all and it got high enough, a buildup of unconjugated bilirubin can be life-threatening. It's deposited in the nuclei of the brain and the nerve cells, causing brain damage. We usually treat this when the bilirubin is close to 10 or 15 milligrams per deciliter, but 20 milligrams per deciliter is incredibly dangerous. So as you saw, we put the baby under the lights and it breaks down the bilirubin. Unfortunately, the same thing happens in a test tube. So if we're drawing blood for a bilirubin, we should protect it from light and put it in an amber top tube. Fasting samples are preferred. Hemolysis should definitely be avoided. So the methods that we use, you need to be familiar with these: Jendrasik, Groff, and Malloy Elvin. Sometimes those come back as board questions. All right, so not only did we talk about bilirubin, once this ends up in the intestines, we talked about urobilinogen. Well, urobilinogen is a colorless end product of bilirubin metabolism that is oxidized by intestinal bacteria to a brown pigment, urobilin. Increased levels in the urine are found in hemolytic disease and defective liver cell function. Absence from urine and stool is seen with a complete biliary obstruction. Most of these use an Ehrlich's reagent to look for a reddish color. So it's important to know increased urobilinogen in the urine with hemolytic disease. That's a big one. One of the last things I'll just bring up is glutamine is found in the spinal fluid of patients with hepatic encephalopathy. Okay, let's move on to some of the enzymes that we use to test for liver function. Some of these you're going to recognize from our enzyme chapter from Chemistry 1, but we're going to review these again. The first set of enzymes are our aminotransferases. Aspartate aminotransferase is found in the liver, but is also found in the heart and the muscle. Alanine aminotransferase, or ALT, is very liver specific. I always remind my students the one that is liver specific is the one that has the L in it right here. Very important to make note that ALT and AST are both very elevated in acute hepatitis. When we see those patients that are in that situation, and usually they have a very icteric specimen, which is very dark yellow, their ASTs and ALTs are sometimes in the 500, 800, sometimes 1,000 range. Next set are our phosphatases. Alkaline phosphatase can be found elevated with liver issues. 5-nucleotidase. Gamma-glutamyl transferase, GGT, that one's often with a biliary obstruction and alcoholism. And lactate dehydrogenase is another one that we will find elevated with liver issues. A few other tests for the liver, especially the hepatic synthetic ability, what they make. The liver does make albumin. So if somebody does have a liver issue, it can cause a decreased albumin. Prothrombin time actually can be increased with liver disease. Prothrombin time is what we use to check to see how fast people's blood is clotting, essentially. Those clotting factors involved in that are produced in the liver. So if the liver is not working, we're not able to create those factors, therefore it's going to take longer or have an increased prothrombin time in the clotting of the blood. Another thing we can look at is a plasma ammonia level. Those are often increased with liver failure. Remember that the liver is capable of turning urea or ammonia into BUN, so it can be eliminated in the kidneys. Well, if the liver is not able to do that, those ammonia levels will build up in the bloodstream. One of the last things we're going to look at are the different types of hepatitis that you can have involved with the liver. Hepatitis in general is an injury to the liver characterized by inflammation in liver tissues. Its cause can be viral, bacterial, parasitic, can be caused from radiation, drugs, chemicals, and autoimmune diseases and toxins as well. What happens to these patients is they get a jaundice or a yellowing of the skin. The urine turns very dark yellow. They have fatigue, nausea, vomiting, and a lot of abdominal pain. The first one is hepatitis A. This is the most common form of hepatitis worldwide. It's usually transmitted via the fecal-oral route. This is the one that you hear about when a restaurant in town or in the area may have had a hepatitis outbreak. This is the type that they're talking about. Usually some type of fecal substance from the person who's infected ends up in the food. The next type, hepatitis B, can cause both acute and chronic hepatitis. This one's usually caused by an infection with a hepatitis B virus via parenteral, perinatal, or sexual transmission. When we test for these, we use it in the serology department. You can see there's all different types of versions. You'll learn about these in immunology next quarter. Hepatitis B core antigen, hepatitis B surface antigen, hepatitis B E antigen. If those markers are present in the serum, they can mean different stages of having hepatitis B. But that is the one that's generally sexual transmission. It's also the only one that is a DNA virus. All the rest of them are RNA viruses. Hepatitis C is caused by an infection with the hepatitis C virus via the parenteral transmission, usually a blood transfusion or IV drug use. When you hear about celebrities with hepatitis, this is usually the kind that they are talking about. Then we have hepatitis D. This is a unique subvirus, which is a satellite virus infection. This means that you have to have hepatitis B before you can get hepatitis D. So this one, you have to have one before you can get the other. If you have both, I would imagine it's a lot more challenging to treat. Hepatitis E is similar to hepatitis A. It's caused by a fecal-oral route, but this one is found more in the waterborne, a waterborne type of thing in developing third world type of countries. Okay, the last two things you'd be familiar with are a couple terms here. One of them is fibrosis. The definition of fibrosis is liver cell injury, usually from an infection with hepatitis B. Then we talk about chronic hepatitis versus acute hepatitis. Acute is obviously very fast, sudden onset. Chronic would be inflammation of the liver for more than 6 months.